All right, let's jump right in. We're about to talk about some of the most powerful and honestly, most common meds you'll ever give as a nurse. We're talking about drugs that literally change the makeup of your patient's blood. This is where pharmacology gets really, really cool, but also incredibly high stakes. So let's get into it.
But before we even get to the drugs, let's meet the stars of our show. I mean, look at these things. They're not just cells. They are legit the hardest working crew in the entire body. They're delivering oxygen, fighting off bad guys, patching up leaks 24/7. And when they need a little help, well, that's where we come in.
So where do these little heroes even come from? Well, to get how the drugs work, you first have to understand the manufacturing plant. So I want you to picture this highly specialized, super high output factory that's running deep inside our bones. And here it is, the red bone marrow. This is ground zero for a process with a big name, hematopoiesis. It's really just a fancy word for the creation of all our blood cells. Everything, absolutely everything starts right here. Now, this factory has three main production lines. First up, you've got your red blood cells. Think of them as the body's personal Uber service for oxygen. Then, you have the white blood cells, who are like your vigilant 24/7 security guards fighting off infection. And last but not least, you've got platelets, the emergency repair crew that rushes to the scene of any injury to plug a leak. So what happens when the factory runs into a supply chain problem? You know, when it can't get the raw materials it needs to build those little oxygen taxis. Well, you get a production shortage, a condition we all know as anemia. At its core, anemia just means you don't have enough healthy red blood cells. And without enough of those oxygen carriers, your body's tissues are basically starving, which leads to that classic fatigue, that weakness, that shortness of breath. And the size of the cells you see here, whether they're too small or too big, that's actually a key clue that helps us figure out what's causing the problem. Okay, so the most common type of anemia is from an iron shortage, and we treat it with iron supplements, right? Ferrous sulfate. You can get them over the counter. They seem pretty harmless, but they carry a very, very serious risk. What do you think is the number one danger with these? This, right here. Accidental overdose in children. Those little iron tablets can look just like candy, and even a small amount can be fatal to a small child. It's incredibly corrosive to their GI tract. This is probably one of the most critical patient teaching points you will ever make. So let's look in these key safety points for iron. First, your patient teaching. You have to warn them to expect harmless dark green or black stools and tell them to use a straw for the liquid form so it doesn't stain their teeth. But the absolute number one non-negotiable priority is keeping it away from kids. Now, if an overdose does happen, the antidote is deferoxamine. And for us nurses, if you have to give it IM, you always use the Z-Track method to keep it from staining the skin. Now, the other key building blocks are vitamin B12 and folic acid. For B12, which we often use for pernicious anemia, the big thing to watch for is hypokalemia, low potassium. But here is the critical can't-miss interaction between these two. Folic acid can fix the anemia part of a B12 deficiency, but, and this is a huge but, it does not fix the nerve damage. So it basically masks the real problem while irreversible neurological damage just keeps on going. The bottom line, always, and I mean always, check B12 levels before starting folic acid. Okay, so sometimes the factory has all its supplies, but it's just kind of being lazy. It needs a kick in the pants. It needs a supervisor to come storming in and yell, "Speed up production." And that's exactly where our hematopoietic growth factors come in. Let's meet our three main production supervisors. You've got ipotinin alpha, which boosts red blood cells, but you gotta watch for hypertension and clots. Then there's filgrastim. Just think, Phil fills up the white blood cells. It boosts neutrophils, but carries this rare, scary risk of splenic rupture. And finally, oprelvicin. I always think O platelets. It boosts platelets, but can cause fluid retention and arrhythmias. Okay, everyone, if there is one number you burn into your brain from this entire explainer, it's this one, 12. If your patient's hemoglobin climbs above 12 grams per deciliter, you hold the epoetin alpha, period. The risk of a heart attack or stroke just skyrockets. This is a critical safety check. For our other two boosters, safety is just as crucial. With filgrastim, you're monitoring those WBCs and you're teaching the patient to report any left upper quadrant pain. And why? Because that drug is making the spleen work overtime to churn out white blood cells, which can make it get bigger and cause that pain. With Oprol-Vacan, it is all about fluid balance. So you're monitoring their I's and O's, you're getting daily weights, watching for swelling, and telling them to report any heart palpitations or vision changes right away. So we've covered how to build the cells. Now let's shift gears and talk about how to manage them, specifically the platelets and this whole clotting process. This is the body's incredible high-stakes emergency response system.
So the process is called hemostasis. When you get a cut, this super complex chain reaction kicks off, and it all ends with the formation of this beautiful, strong, fibrin mesh that traps blood cells and seals the wound. But sometimes we need to intentionally slow this whole process down. Now, I know this can seem really complicated, but let's just simplify it. There are basically two main roads that lead to a clot. You've got the intrinsic pathway. Think of it as an inside job, like damage inside a blood vessel. We monitor that with the APTT lab test, and it's the target for heparin. Then you have the extrinsic pathway for an external injury. We monitor that one with the PT/INR, and that's the target for warfarin.
Let's just hammer this home one more time because it is that important. Heparin hits that intrinsic pathway, and we monitor it with the APTT. Warfarin, on the other hand, is a vitamin K antagonist. It hits the extrinsic pathway, and we monitor it with the PT/INR. It's a really simple way to keep them straight.
Phew, we have covered a lot of ground. But now we are boiling it all down to the absolute must-know, can't-forget safety points. Really, this is your job in a nutshell. Ready? Let's do a rapid-fire review.
This sentence, I want you to memorize it. Say it to your patient. Because if you don't warn them about this, they will absolutely think they have a major GI bleed, and they will panic. A little proactive teaching here prevents a whole lot of unnecessary fear. Remember, hypokalemia with B12. So why does this happen? Well, think about it. As the body suddenly ramps up production of all these new red blood cells, it uses up a ton of potassium in the process. That's why you have to be on the lookout for signs of low potassium, like muscle weakness. If you remember nothing else about vitamins today, please remember this. Giving folic acid can hide a B12 deficiency, and that can allow permanent, irreversible nerve damage to happen. It is an absolute fundamental rule of safe practice. Check the B12 level first. And for our growth factors, our factory supervisors, here are the big don'ts. Don't shake the vial, you'll destroy the protein. Don't mix them with other meds. For filgrastim, be really careful about timing it around chemo. And for epoetin, I'm going to say it one last time. Always check that blood pressure and that hemoglobin level before you give it. So, let's just end with this. I want you to really think about it. You've gotten your order, you've pulled the medication from the Pyxis, whether it's iron or epoetin or warfarin. What is the very first lab value, the first vital sign, or the first piece of patient history you are going to check before you even think about administering that drug? Because that right there is where patient safety begins.